Welcome to Mindful Bell Med. Let's talk about the trauma assessment. After dispatch, establish BSI and PPE precautions. Next, scene size up. Assess the scene for personnel, patient safety. Look for environmental hazards, number of patients, mechanism of injuries. Determines the need for additional resources, specialized equipment, additional BSI, spinal motion restriction. Instruct the headman to hold manual stabilization of the patient if indicated. Primary assessment. Formulate a general impression of the patient, stable or unstable. Establish patient's rapport. Introduce itself to the patients and or family. Determine preliminary chief complaint. Obtains permission to treat. Next, assess the mental status or stimulus response. Is the patient tracking you? Is the patient responding to verbal? Does the patient respond to painful or noxious stimuli? Is the patient unresponsive? If found unresponsive, checks for carotid pulse and breathing. Ask for AED and perform CPR if indicated. Ask the patient for orientation status using PPPT. Ask, what is your name? Where are you right now? Why was 911 called? What year is it? Verbalize the A and O scores. Continue to assess the ABCs. Explain that the care is being delivered to the patients. Assess the airway. Is it patent? Is it obstructed? Manage the airways in life-threatening situations by open the airway, clear the airways. Insert an airway adjunct if indicated. Transport immediately if unable to open the airway. Determine whether the airway is manageable versus unmanageable is very important. Next, we assess for breathing, looking for the rate, rhythm, quality, and depth. Perform rapid chest auscultation. If difficulty breathing, shortness of breath, or chest trauma. Then, manage the breathing. Applies oxygen if indicated. Positive pressure ventilation if indicated. Transport immediately if unable to manage the airway. Next, we look at the state and indication for immediate high flow oxygen administrations. We look for respiratory arrest, cardiac arrest, shock or poor perfusion, anaphylaxis, traumatic brain injuries, carbon monoxide poisoning, suspected pneumothorax. Again, we state indication for immediate high flow oxygenation if we see respiratory arrest, cardiac arrest, shock or poor perfusions, anaphylaxis, traumatic brain injuries, carbon monoxide poisoning, suspected pneumothorax. C. Assess for circulation using the COPS mnemonic. C for capillary refill, O for obvious external bleeding, P for pulse, Is it too fast, slow, or absent? Next, look for skins, for color, temperature, and moisture. Then we manage circulation in life-threatening situations. Place patient in supine position if hypoperfuse is suspected. Controls external bleedings. Note to transport immediately if unable to manage airway. Next, we observe for deformities and disabilities, looking for neurologic deficits, abnormal body presentations. Then we expose and visualize the area associated with the preliminary chief complaints. To review, A, B, C, D, and E. A for airway. We look for blockage, cervical spine injury. B for breathing, looking for tension pneumo, pulmonary edema, bronchospasm. C for circulation, we look for signs of shock, such as hypovolemic shocks, obstructive shock, distributive shocks, or cardiogenic shock. D for disability, looking for seizure, hypoglycemia, meningitis, intracranial hemorrhage, or infarction could cause disability in the patient. E, we expose the patients looking for signs of hypothermia, hyperthermia, or critical signs skin conditions such as fasciitis or urticaria, hives. Next, we form a field impression. Manage life-threatening situations. If patient has altered level of consciousness, also obtain blood sugar. Then we determine the appropriate transport decision. Is it AOS level, BOS level? Should the patient be transported by ground or air? And the destination to appropriate facility. Next, we instruct a legman to obtain vital signs and sample history from either the patients or bystanders. Next, we perform secondary assessment, looking at the patient's head to toes for signs and symptoms. We visualize for deformities, contusions, abrasions, penetration and punctures, burns or bruises, tenderness, lacerations, swellings, scars. And we palpate for tenderness, instability, crepitus. The mnemonics is decap, BTOS, and tick. Again, we visualize for deformities, contusions, abrasions, penetration and punctures, burns, bruises, tenderness, lacerations, swellings, and scars. We palpate for tenderness, instability, and crepitus. Assessing the separate parts of the body from head to toe. For the head, we look for decap, BTOS, tick. We use a clean gloves to do a blood sweep of the scalp. Palpate the skull and facial bones. For the ear, we look for vital signs, blood, CSF leakage. If there are fluids coming out, we perform the halo test. For the eyes, we look to see if it's pearl. Look for raccoon eyes, redness, contact lenses. For the nose, we look for blood or CSF leakage, noting the need for halo test if indicated. For the mouth, we look for avose teeth, bleeding, unusual odors, or any airway adjuncts. Moving on to the neck, we look visual and palpate for decap, BTOS, tick, looking for step-offs, JVDs, tracheal deviations, stoma, medical tags, subcutaneous emphysema. Before moving on, We apply a C-collar and trauma naked. For the chest, we visualize and palpate decap BTOS tick, visually looking for any paradoxical movement or flared chest segment, and looking for open pneumothorax. Then we check for shoulder stability, subcutaneous emphysema, perform the barrel hoop maneuver again, do a sternal rock, and auscultate lung sounds and heart sounds. Moving on to the abdomen, we visualize and palpate for decap BTOS and Dr. Germ. Dr. Germ stands for distension, rigidity, guarding, evisceration, rebound tenderness, and pulsating mass. We palpate all four quadrants, doing light palpations and deep palpations. Moving on to the pelvis, visualize and palpate for decap BTOS tick and looking for additional signs of priapism, incontinence, and genital bleeding. We also look for open book injury by palpations. Next, we look at the extremities, upper and lower extremities, visualize and palpate for decap BTOS and tick, and looking for PMSCs, pose, motor, sensation, and capillary refills. We also do offset pressure to look for any bone breaks. Then we log roll the patient. When log roll, we look at the back of the patient, visualize and palpate for decap BTOS tick, specifically looking for step-offs, auscultate lung sounds, look for signs of incontinence and genital bleeding. We roll the patient onto a long backboard and prepare for transport. It is important to also note for signs that shows neurological status. Determine the comprehensive orientation of the patient, the GCS levels, what the pupil findings are, and the glucose. Then we determine the severity of the patient and reassess the patient. For stable patients, reassess every 15 minutes, unstable patients every 5 minutes, and for critical patients, we reassess every 2 minutes. Finally, provide an accurate radio report. That is all for the medical assessment.